Next, we're going to do a live simulation where I'm going to be the subject, but before we do that, we're going to invite Helena, FILIPE to come up and to sort of set the stage for that.
Mr. Chairman, thank you so much for the opportunity. So, I seem not to be passing the slides. Cannot run. So we have the first slide already. And we have seen, have heard from the previous presentations, a very good set of the stage of the opportunities, of the possibilities that we have in the clinic to address presbyopia, and also the challenges of explaining exactly what is to be expected by using one or another, or mixing them as well. And so this presentation would be to share some technology and a technique as well that can make the patient really experience what is about choosing one or another, or mixing both, and have this immersive experience using being as if already has been operated on. So I hope this. Okay, so despite technically perfect surgery, how many of us have had patients dissatisfied with their IOL choice, even with the best explanations? And we have already heard about the differences that the many possibilities that are on the market in IOLs can offer. They are all different, certainly much better than a cataractous lens can offer, and also a little bit lower than a 25-year-old healthy eye, but much closer to that. And these differences can be the exactly key for a satisfied or an unsatisfied patient. So unmet patient expectations are usually concerning dysphotopsias, depth of focus, contrast sensitivity, and vision in different lighting conditions. And these are very difficult to explain when we think about choosing the best patient. We always know that that selection is a mismatch as well of our personality and our choices, and the person that we have in front of us, the patient himself. So how can we choose? And our proposition is to introduce live simulation to replicate what happens as if the IOL was already in place before surgery. It relies on technology that is supported by adaptive optics, mimics post-operative optics in real time, virtual reality simulations, and can provide this immersive experience to the patient as if he or she is already using the IOLs, and also wavefront guided imaging as a technique. We will see in a minute. The person looks through a simulator and have this experience near, intermediate, and distance vision, and also can test different IOL types, as we have heard before, and have the experience and the sensation as if were already operated on, and make a better choice with here or his doctor. So there's evidence sustaining that this technology provides reliable information regarding what will happen, to anticipate what will be the sensation, the feeling of the patient with the new IOL. And also, there's also experience as well at the clinical practice. For instance, this is a case of a 50-year-old patient considering a trifocal, and after simulation and the difficulty adapting to halo effect, a need-off lens was chosen, and the outcome was fully satisfied with no post-op regrets. There are already also other applications of this technology, of this immersive experience, not only for IOLs, but also for contact lens, laser presbyopic surgery, fine-tuning the right binocular combination. So a whole world of reality, new reality, can be devised and built for the patient to experience before. So in summary, life simulation for better overall surgical outcomes will enhance patient education and shared decision making, and not only this, but also reducing the time that is needed for explanations, enables personalized IOL selection based on the lifestyle and the personality of the patient, and also will lead to fewer post-op complaints and regrets in IOLs exchanges. And virtual reality and adaptive optics and artificial intelligence-driven IOL simulations will most probably become standard and be used in the future. So we have now a live demonstration of the technology. So we have already Professor Kruger experiencing the simulator. And we have to wait a little bit, so this can be done at the office during a consultation. And besides explaining and having images and having booklets for the patient and having the time that all patients deserve when explaining everything and emphasizing the choice for the IOLs, we can see that our time is already very well taken for this experience, because the patient can live in a kind of a second life virtual reality of an immersive experience. So it has to be adjusted for the refraction of the person, and then we can try an head-off and ask Professor Kruger, what is the experience?
Sure. So just to start, I have not had any cataract surgery. I'm a slight hyperope. I am wearing a contact lens that allows me to use monovision. So I've been used to monovision in the past. And right now I have a simulation that's giving me distance in both eyes with an EDOF, a Vivity. And I can see the distance pretty well with no real distortions. And I can read pretty nicely all the way down. So I think I've got decent range with this.
So
okay.
The near and far, comfortable.
Okay.
Okay, let's try another option. And this would be a mix and match.
Okay, mix and match. So I
Near
can
and far.
see the distance pretty well. Maybe it's not quite where it was before.
With the head off. And now the near vision.
The near vision is also pretty good. But I don't think it's superior to what I had when I was just wearing the EDOF. So maybe I'm one of those people who just needs a little bit of extra range of near without having the full range.
Okay, so before this, we can see that this experience will help us a lot, and especially will help the patient a lot in terms of selecting and take a shared decision of what would be the best choice for the patient.
So maybe we'll try to see if a bilateral trifocal, what it looks like for me.
Okay, let's try a trifocal.
1 minute to go.
One minute to make it happen. Okay, so this is trifocal.
So magic.
So I noticed that the distance doesn't seem as robust and clear with the trifocal. And I can see pretty well up close, but I don't think it's worth it for what my distance was when I was using the EDOF. So I think my vote would be EDOF.
EDOF. Thank you so much, Professor Kruger. Thank you so much for your attention.